I'll be speaking on therapeutic keratoplasty. Yeah, I'll be speaking on therapeutic keratoplasty, when and how to do it. The basic indications of therapeutic keratoplasty is when the keratitis is more refractory and not responding to the conventional conservative treatment, and the infection is going towards the limbus, or it is penetrating deeper with an impending perforation as an actual perforation. The indication can be further divided as per the causes, like infectious and non-infectious. So these are the kind of presentation which we usually see in our clinic, because the patients in India tends to present quite late. So we mostly have patients where the infection is already extended up to the limbus, or it has perforated with sometimes lens extrusion or vitreous prolapse, or sometimes endophthalmitis also. The goal in these cases is to get rid of the infection or non-infectious inflammatory tissue, and to restore the structural integrity of the eye to provide a tectonic support. But the leading question from the patients is always about the vision, and they always ask whether they will get a useful vision after this procedure or not. So we have to give a good cheer time to the patient, to counsel the patient and bring down the expectation of the patient, so that he get a real picture of what we are going to expect after the surgery. Once the patient is well counseled, then we can refer the patient to a general physician for a clearance for the surgery. The choice of anesthesia in these procedures usually depend on the age of the patient and type of the presentation. In pediatric age group and in patients presenting with large perforation with lens prolapse and vitreous prolapse, you might prefer a general anesthesia. Otherwise, you can try a combination of peribulbar anesthesia along with facial block. Mostly these patients, we can give intravenous mannitol 1 gram per kg body weight around 1 hour prior to surgery to reduce the positive vitreous pressure, which most of these patients have. The ocular assessment is very important, a thorough slit lamp examination to check the margin of the infiltrate and to see how much the infiltrates are distant from the limbus, the actual depth of the infiltrate, any perforation if it is there, presence of endothelial exudate, anterior chamber exudates, the lenticular status, it's all should be checked. If the fundus is not visible, then we can take help of a ultrasound, B-scan ultrasound, to note the fundus to retina status and to rule out endophthalmitis in these cases. We can actually make a color-coded photograph of the cornea and take it in the OT for helping in the surgical planning. This is very useful practice, which I usually follow in my in these cases. Measuring the corneal infiltrate can be tricky sometimes, because the eye can have a lot of exudate in the anterior chamber and on the endothelium. So what I usually do is, like in these cases, we can make a paracentesis and wash the anterior chamber with Valence salt solution. And once we wash all these exudates from the anterior chamber, we can actually judge the actual size of the infiltrate, and then we can make our decision on the refined size, like in this case. In all these cases, putting a Fleringa ring before doing surgery is starting the surgery is a must, because most of these cases presents with perforation and a positive vitreous pressure. Like in this video, as I am trying to open the globe, you can see the lens is popping out. So along with the crystalline lens, sometimes the vitreous also prolapse, and it can cause the globe to collapse. So if you have Fleringa ring in place, then you can definitely have more reliable suturing in these cases. Fortunately, in this case, I didn't have a PC rupture, so I was able to manage the case. You can have in these cases, you can have iris exudates. These exudates are present on the surface of the iris, on the anterior surface of the iris, which you can peel with the help of forceps, or you can have retro iris exudate. Like in this case, there's a lot of retro iris exudates, which I'm trying to kind of scratch with a visco cannula, trying to keep the posterior capsule intact, and trying to just scratch the posterior surface to remove as much of exudates as possible, and then you can remove them with the help of forceps. So these exudates can be there, which have to be tackled. Now, in some of these cases, you can have a large perforation. So if you give a peribulbar block straight away, you can end up with a positive vitreous pressure, which can cause expulsive choroidal hemorrhage. So what I usually follow is to put, in these cases, before blocking the patient, you can put glue at the perforation. You can just put a little bit of glue, and you can use pars plana vitrectomy to reduce the vitreous thrust. And if you do not have access to a pars plana vitrectomy, what you can do is a gentle vitreous tap with a 30 gauge needle to reduce the vitreous volume and a positive vitreous thrust. Just 0.05 cc of vitreous can be tapped, and this will reduce the vitreous thrust considerably, and you will have the risk of expulsive choroidal hemorrhage will be much less. Now the patient can be taken for peribulbar anesthesia. Now this is a case where there is a very large perforation with iris prolapse and vitreous prolapse. So before doing the surgery, you have the corneal button, disease corneal button. Now it's important that when you cut, you see what you are cutting, otherwise you will cut the iris. In this case, as you can see, the iris is totally plastered to the corneal tissue. So you can lift and gently cut with the help of vanas. You have to lift and see what you're cutting again. So here I'm just trying to separate it from the underlying plastered iris tissue. And after removing this, again I can see there is a whole fibrosed complex around the lens. So I'm trying to do a vitrectomy to release all the vitreous strand over there, and then remove the IOL. Once IOL has been removed, I'm doing anterior vitrectomy. Any vitreous over there has to be removed. Now what I'm doing here is to make the trephine edge more vertical by removing the excess tissue with the help of corneal scissors. This vertical edges are important so that your suturing and all is more perfect. Once this has been achieved, you can here I am removing all the fibrosed capsular thing which is adherent to the iris. And once it is achieved, then you can do a vitrectomy again. And here in this case, it was done under a lockdown last year, so we'll use the glycerol preserved tissue. It's a glycerol preserved tissue, and you always put interrupted suture, not continuous suture in these cases, with tenon interrupted sutures. And last I removed Flaringa ring. A lamellar keratoplasty can be tried in therapeutic keratoplasty cases, but it has very limited role if you are very sure that the infection is in the superficial layer only. Then only do a lamellar keratoplasty. Otherwise, you will end up in a situation like this. This was a case of fungal keratitis in which a lamellar keratoplasty was done elsewhere. And here you can see when I'm removing the anterior donor tissue, there is an interface keratitis with a perforation. So to be very, very sure that you have completely removed the infection, otherwise you will end up in situation like this if you're trying lamellar keratoplasty for therapeutic purpose. Patch graft, as Dr. Gautam has nicely demonstrated. Again, patch graft has limited role for smaller perforation. Like this is a case of Sjogren's syndrome with a melt. This is a 300 micron guarded knife. I'm doing making a 360-degree groove. So in case of small perforation, you can try this. And once a groove has been made, you can remove the necrotic dead tissue with the help of forceps, and leaving the actual perforation is quite small, and then there is a lamellar layer of corneal tissue. So I'm just debriding the bed further, and this is actually a DMAC leftover tissue which we are using here as a patch graft. Usually 6 to 8 sutures, interrupted corneal sutures, are sufficient for these cases. Once this has been achieved, you can use BSS to form the anterior chamber. Now this is a case of Sjogren's melt, so I'm using chromic catgut for temporary punctal occlusion in these cases. Adjunctive procedures like punctal occlusion and tarsorrhaphy are usually helpful in cases like this. So the follow-up of these cases is very important, as these cases require a closer follow-up as compared to optical penetrating keratoplasties, because these patients may have intraocular pressure, raised intraocular pressure, because of the presence of peripheral anterior synechias and associated inflammation. So you might want to add up anti-glaucoma medication, and in very rare cases you might require a trabeculectomy with mitomycin C in these cases in post-operative period. There is chance of recurrence of infection, which you have to discuss with the patients preoperatively. So you have to make a close follow-up, and a very cautious use of steroids is required in these cases, because I usually follow that for bacterial cases, bacterial infection cases, I usually avoid steroid for the first 10 days, and for fungal, I usually don't give steroid. If at all I have to give steroids, then it has to be given after 6 weeks of in the post-operative period. Regrafting for an optical purpose in these cases, usually I defer for about approximately 6 to 8 months. Once the inflammation settles down and you have a good chance of success for the optical graft, then only I take up for this thing, regraft for optical purposes. I thank you for all your patient listening.